first speaker is Dr. Vanessa Pinfold. Vanessa has worked in mental health research for over 25 years and has published studies on stigma and discriminations, families and carers, experiences of mental health system, well-being network, and co-production in mental health research. She is now prioritizing developing peer research method through collaborative or production approaches. She currently chairs the Alliance of Mental Health Research Funders and is a co-founder and research director at McPin, responsible for overseeing the work of the charity.
Thank you, everybody. Thank you. It's a privilege to be here, and it's lovely to see some of the people that I was spending time with on Thursday as well. We ran a workshop, started to think about lived experience leadership in research and how we might be able to develop that work further in Israel. So my talk this morning is really focused on research collaborations. I'm going to talk about lived experience involvement, some of the concepts and background, and importantly, the skills that we need to use to do this work really well. And I'm going to talk about a couple of studies in practice where this has happened. They're both focused on medication use. And I'll end with some reflections about how we might work together going forward. I'm a researcher. This is kind of a methodological talk. And my main message is embrace this way of working. If you're a researcher, if you're planning work, if you're thinking about getting involved in research, I actively encourage you to do this, and to do this by placing at the centre the expertise of people with lived experience. When you're talking about lived experience work, I think it's really important to start from a place of acknowledging why you're doing it yourself. And I suppose I just want to acknowledge that my journey with this work is quite long. And I started at university, got very, very interested in mental health when I realised that my aunt took her own life and a lot of my friends developed serious mental health problems. And I couldn't understand why I was at university and no one had told me at school there's this thing called mental illness. And I think looking back, it made sense to me about some of the struggles I'd had as an adolescent. Now, in the UK at least, that's less common. There's a lot more mental health awareness, and it's partly to do with the Time to Change campaign. And I was very lucky that I worked at Rethink Mental Illness at the time, and I was one of the key leaders of the Time to Change campaign, getting the money behind that. So I've always, in all my work, tried to place at the centre of it expertise from experience. And I was very lucky that I've worked in both the university environment at King's College London, and I've also worked in the NGO, we call it charity, voluntary sector organisation in the UK, and I set up the McPin Foundation. I'm Pinfold, my husband is McNally, we are the McPin Foundation, and we run an organisation that's just celebrated its 10th birthday, and that's the team there celebrating. And I think that it's really, really important, and I feel the whole emphasis of our charity is by thinking about how we open up this thing called research. Whether you're doing a randomised control trial, a systematic review, whether you're doing qualitative work, whatever the methodology that you're using, there is space within the team for people with lived experience. Our portfolio at McPin is broad, and one of the things that people say to me is, what's the most important thing about your organisation? What does success look like for you? And I say to them, the well-being of my staff. The most important thing is the people. The people bring their expertise to the table through their work, and they do that in various different ways. And I'm going to talk a little bit about that today, because lived experience isn't one thing or another, it's lots of different things. And one of the ways in which we ensure that people can work well in this way is that we provide a really big package of support around them, and we support each other. We do peer support, but we also have mentors, we have wellbeing programs. I buy everybody a birthday present every year. There's something about the culture of an organisation and the values of it that are very, very important in kind of embedding this kind of work. But we've done lots of different projects over those 10 years around recovery, a lot of work working on thinking about transforming mental health services, but also developing new treatments. And our website is got lots of information on it, and I encourage you to visit if you want to know more. So, just to sort of start so we're on the same page, I thought it's quite important to kind of define what I mean by patient and public involvement. And the best definition really in the UK comes from the Health Research Authority, and it says public involvement in research means research that is done with or by the public, not to, about, or for them. It means that patients and other people with relevant experience contribute to how research is designed, conducted, and disseminated. I think the most important thing is I'm not talking about research participation. Research participation is very important, but I'm talking about partnership, colleagues, working side by side. The statistician, the trial manager, the qualitative research leader, we're all working together. And why? There's a whole list of reasons up on this slide. They kind of fall under the social justice element because it's a really important thing to do, and it's about rights and it's about epistemic justice, but it's also about the technical reasons, and your research will be better. You'll recruit to trial, recruitment rates tend to be better, and retention rates in trials tend to be better. So there's a whole raft of different reasons why to do it, and each of these are starting to have an evidence base behind them. And people are writing both philosophical and epidemiological and kind of practical reasons about why this stuff matters. It's not just me standing up here saying it's really important, or other people. There's a very large movement across the world that are doing this. But there is lots and lots of rationale behind it now, and I think that's really, really important. And at McPin, we're trying to write more about this work. So it's, again, not something that's seen as this like little fluffy thing over here, but it's at the heart of the research agenda. Lived experience expertise. So when I ask my team what it is, this is the kind of working model that they're coming up with at the moment. So we talk about lived experience and the knowledge that generates through those experiences. And then you think about the skills of applying lived experience in research. And that happens through different roles and using different methods. But it's the combination of the lived experience element and the skills that come together through this thing called lived experience expertise. And there's a continuum along the bottom of roles you'll find familiar in research projects. And lived experience can be found in each of these individual roles. And when I say lived experience, I don't only mean mental health. I'll come on to that in a minute. So there are different models that you can use. So these are some of the terms that you'll see when we talk about lived experience work in research. Patient and public involvement, co-production, participatory action research, peer research, and user-led research. And again, there's a whole theory and there's lots of writing behind all these different things. Public and patient involvement in research is often advisory roles where people join groups and they work alongside the academic team, but they're not doing the research. Whereas some of the other methodologies on that and models on that slide are much more where you're active, part of the team going out and collecting research data and analysing. As I say, there are different roles here. So you can be an advisory group member, you can be a co-applicant, you can be a research collaborator, a peer researcher, and you can be a leader. And one of the things we're trying to shift the dial on is seeing a lot greater leadership roles for people with lived experience. It won't be a surprise to people that there's a lot more people in advisory groups than there are as chief investigators. And this takes time. Just want to note a word about language. So I'm using the term lived experience, but there are lots of words, there are lots of labels, and people use the label that feels most comfortable with them in their role. At McPin, we say to people that most of our job roles are called peer researchers, but some people don't like that term. They want to be called a researcher, or they want to be a service user researcher. So we say to people, you choose the role that feels most comfortable and relevant to you. But it's important that we're talking about this family of patient, consumer. We're also talking about family members and carers. You can be a peer researcher as a family member and using your expertise in that way. So there's lots of different ways in which we might phrase these things, but at the heart of it is understanding that the knowledge that this lived experience gives you. And the other thing that I want to just acknowledge is that this doesn't sit just in the patient role. We have lived experience that spreads across clinical, academic, and experiential roles, and we often wear many hats. And I think one of the key things that we're trying to do is encouraging people maybe that have clinical expertise and bring clinical expertise into a study to be thinking also about whether they have lived experience expertise as well that might be relevant. The same in terms of academic expertise. Often people have lots and lots of expertise, but they don't always feel comfortable stepping into the patient role in a research project. And one of the reasons for that is power, is stigma. There's lots and lots of challenges around, sharing our different identities, and we're trying to kind of flatten all of that, bring it to the fore and say, let's work together collaboratively and let's think about the different expertise that we have and really ensure that we are bringing more people with from a service user, survivor, patient perspective into our studies and skilling them up to do the work that we do. Intersectionality. So when I say we're talking about lived experience expertise here, we're really talking about intersectionality. We're not only talking about the experience of being within the psychiatric system. That is central, but it's more than mental health challenges. Obviously, the context in which we live and our various different identities really shape who we are, and that's in a sense what we're talking about when we're thinking about this work. A dear friend of mine who works on one of our studies said to me, I joined the Partners 2 Leap as someone who used mental health services, but I also brought other identities, some more visible than others. Care for my mum, ethnic minority background, gay man, Muslim. Research will benefit from including all those perspectives, but only if I feel safe and can choose whether and how to reveal them. So, when we're working in this way, we have to work very carefully and we have to ensure that we put some parameters around this. And there are some really key sort of principles that we work with. The first thing is creating safe spaces. We've just developed this guide actually. It's developed with young people who have been involved in research, and we asked them what was important to them. And one of the key things they said is that we need to create safe spaces for them to come and bring themselves to work alongside us. We have to foster trust. We need to think about confidentiality and consent within spaces. And we need to be clear that some of the work that we might be doing could be really difficult, and what are we going to do about that if people feel triggered or if they feel that their well-being is impacted by the work that we're doing. So not in a paternalistic way, but in a very open and authoritative way, trying to think about how we create a plan for everybody to bring themselves into this space and work in this way. So safety, safe spaces is really, really important in lived experience work, in research. But so is power sharing, and this is really tricky, and it's really easy for me to say this, but I have worked in this work for about 10 years, and it is a tug of war often, and it's no one's fault for that. It's just the systems that we work with. It's often not the individuals, but it's the systems. Universities are very, very hierarchical. The way you get promoted is there's some key kind of pathways that you have to follow, and a lot of the work around lived experience work uses skills that are not valued by the academic system necessarily, and the amount of time and resources it can take to do this work means that sometimes people just can't do it or find it or struggle to do that. So I think that we have to just acknowledge this issue, that if we're going to work in partnership with people with lived experience, we have to think about creating those safe spaces, but also what are we going to do in terms of sharing power. And when I say that, I'm really talking about decision making. Who decides what research we're going to do? What outcome measures are we going to use? What's the interview schedule going to look like? How many interviews are we going to do? Lots and lots of very big and micro decisions in projects sometimes get made by one or two people, not the whole team. And in this kind of work, when we're thinking about co-production and collaborative work, it's really important to try and be really transparent about how decisions are made. And often what we say is we can't all be involved in everything, but we can have a system and some transparency and say what the parameters are around that and show where people can make a difference and feedback where they have done. So again, none of these things are simple, but these are some of the principles that we're trying to work towards all the time. And the budget issue is we're trying to shift the budget pie so a little bit more money goes into lived experience work, because often it's seen as the last thing that gets added on at the end, and sometimes there's no money at all to pay for it. The other thing is a very commonsensical, but it's really important that we're basically, so much mental health research work is relational. The teamwork that you build, the trust within the team, and we need to be developing respectful and meaningful relationships with our service user, patient, carer partners. And it involves, we also need to acknowledge that some of this work does involve emotional labour for all of us, and how are we going to support that. And it's really important that we're thinking about role development as well. So for all the people in our advisory groups, we have a little personal development plan for everybody, thinking about if they're going to work with us for 3 years and they're going to come to a meeting every 4 months, say, so it's not a lot, say 3 times a year we meet, but in those 3 years, having met 12 times, what do they want to achieve? and ensuring that we're really clear that this is all about development. The key thing as well is we have to prevent the risk of tokenism and the extraction of people's expertise so that we progress with our careers and people in our groups are like, well, I shared lots of stuff with you and I helped you in your research, but where am I in all of this? So the key thing that we look at is reciprocity, and it's not only about financial exchange, it can be other ways in which people can gain from being part of mental health research. And I suppose one of the things that I think about is that it's part of people's recovery journey. A lot of people, over 100 people are working with me at the moment, and that part of that development is that we hope that they're developing skills and confidence that will help them move forward in their career. And so this is part of a recovery movement as well as being part of a research agenda. There were lots of skills that are needed to do this, and I don't really have time to go into them all, so I'm just going to flick through these slides. But the key thing is that this work is skilled. Going to an advisory group, being a peer researcher, these are things that are carefully skilled. And we need to be thinking about that and building the methodology, and we're at the beginnings of doing that. There are also challenges. I'm not standing up here saying everything's easy, but it's worth thinking through the challenges and trying to work together on some collective solutions. Stigma and discrimination is quite important here. I kind of alluded to it earlier in terms of the titles that people use. If I come to a room and I stand up here and I'm a peer researcher, then everybody knows that I'm sharing part of my identity, but not everybody wants to do that all the time. So again, in our team, we're really careful about the expectations that we put around people and the choices that we give people. There's also lots of literature around this. So my slides, you'll be able to get access to my slides, and there are lots of papers, and I've just put some pictures up there of some of the really important piece of work that are helping to shape what I'm talking about today. So the foundations that I'm standing on are rich, and they are many, and it's really important that an organisation like myself is acknowledging that. So if you're interested in this kind of work, there is a huge literature that you can access. You can also access our literature, and these are some publications that we've been developing. So after 10 years, we've decided that rather than just have things like in our heads, and we need to be writing more. And writing is really difficult. And what we've done in these practical guides is not tell people how to do these things, but trying to share our learning, some of the challenges, and what my staff have found really important, and what the staff have found is that the essence of co-producing research, working as a co-researcher, this is young people, we talk as co-researchers working alongside an academic, often doing co-interviews together, and more generally about using lived experience in the workplace, whether it's as a researcher, whether it's in my comms team, whether it's as an administrator. In a charity like mine, lived experience is found in every pocket of the organisation, not just within the research and the PPI team. So, what about studies that we've done? I want to just briefly talk about 2 studies, just to give a kind of overview and maybe sort of dig down in a little bit more detail about what I'm talking about here. So one of the first studies I did at McPin was looking at antipsychotic medication in pregnancy. It was a large database study where we were pulling together NHS records and GP records, and the researchers wanted to look at what are the risks and benefits of taking medication from a group of women who had a diagnosis of psychosis versus other people. And in order to do this work, they wanted to get together a group of 4 women who had experience of antipsychotic medication and were of childbearing age, because they would bring their expertise into study as women that were matched to the group that we were looking at in the data. And the first exercise they were asked to do was to look at all these risks and rate which was the worst one. And they said they couldn't do it. They said they were all awful, and how could you ever try and prioritise one risk against the other? And the group said, oh yeah, that's a good idea. That's, okay, I understand that. So how would you come to deciding whether you're going to take medication or not when you're pregnant? And they said, well, can we go and ask some more people about this? Because it's complicated. And each of the 4 women in our group had a different approach to it. So we did a nested qualitative study within this big database piece of work. And we went out and we interviewed 12 women about their experiences of weighing up the risks and benefits of taking medication during pregnancy. And we came up with, this is one of our team is very artistic and helped us to provide a summary of some of our findings at the end, and this is one of the graphics. But essentially, the way in which those 4 women shaped this study was they had the idea that it was important, that the research wasn't going to find out these things unless we asked some women and we did a qualitative piece of work. So they designed the study, they developed the protocol. They went out and recruited the 12 people. They did that through their own personal networks and through social media. It was quite hard to find people that wanted to talk to us about this topic. So we weren't using, this wasn't systematic, it was 12 selected people, but they all had very, very powerful narratives. They developed the recruitment materials and they clearly outlined the role of the peer researcher. So every woman that took part in this study knew that there was another woman that was going to meet them that had a similar experience, that had something in common with them. And we found in those interviews that actually that was quite important for those women in terms of building empathy and trust, and in order to tell their story about what was a really, really difficult decision that they were weighing up at a point in time. Obviously, all the women we interviewed had been through this process. Some people had lost their babies. One woman, his baby had been taken into care. Quite a few women had relapsed during the process. There were really, really painful stories that we were holding. And the 4 women that did the interviews also did all the analysis, and we came up with various different analysis frameworks, and they co-produced the paper for write-up, and it's available. So at every step of the way, I was there and another lady was there providing sort of a coaching process for amazing women to lead this piece of work. And the write-up stage is the hardest, and in all honesty, I did quite a bit of that. But the key thing around this was gaining permission to do that with them. Which we managed to do, and it took nearly 3 years to write this piece of work up, but we did manage to do that. And the key thing was looking at this dilemma that women face, and thinking about the factors that influence women in that situation. So that's one example of a study where we have integrated lived experience expertise into a piece of work. The second example, actually, Nicola and Maeve are going to talk in detail about some of these things. I think Nicola's definitely going to talk about some of this stuff, which is called the RADAR study. But we were the PPI partner, the patient and public involvement partner in this study. So this is a study looking at a trial of a group that were going to be supported to discontinue antipsychotic medication. And the interesting thing about this study is it started with, as all research projects start, with an idea that didn't come from nowhere. It came from lots of clinical experience, it came from academic work, and it came from talking to lots of service users and carers about the dilemmas and the challenges of side effects of medication, the fact that it would be quite good to have some help coming off these medications. So the PPI, when you get a grant, you have key leaders in research, and so 4 people within the panel, this is quite rare, 4 people out of about, I think there was 15 co-applicants, 4 of them were working from a lived experience public perspective. There was a carer, a service user, a public information expert, and me. So we provided input from the very beginning around the things that we thought were important. And then we also created what we call a lived experience advisory panel. So 7 people, all passionate about exploring how to safely reduce medication, formed a group. And over the 6 years, we met regularly, and they helped to challenge the research team, asking questions, and help shape some quite important aspects of the study. And as we went along that journey, one of the things that I recognised was that each of the members of the LEAP, so the 7 people in that LEAP, their relationship with medication was changing. because you're not stuck in time sitting on an advisory group and all you're doing is advising some researchers. Your life is changing, obviously. And Radar had an impact on those 7 people. They gained new knowledge. They were working with Professor Joanna Moncrief. They were exploring their own medication use in different ways with their psychiatric team. So what we decided to do was a reflective piece of work on our own journey. So the research actually impacted on the 7 LEAP members, and we then decided that we would explore what that looked like for people. In this study, I think it was really important to acknowledge that using lived experience wasn't always easy. Sometimes there are parameters within research studies that mean that it's difficult to do what you want to do. So the LEAP very early on wanted to have, were really interested in kind of teasing out what this thing called relapse is. And they felt quite strongly that relapse and withdrawal symptoms are different things, and how is this going to be separated out in the trial? And there were differences of opinion on whether the trial should have an element of peer support in it. So there was lots of different ways in which this piece of work benefited from having that expertise from 7 people. And one of the things we always try and do is, even when people make recommendations and they're not travelled forward, we make a list and we have what we call an impact log. So there's great transparency all the way throughout that people are recommending something, and then why a decision is taken or not. It comes back to that transparency around decision making that I was talking about. So we try and make sure that all of this different input, people can get feedback on what made a difference and how their role was meaningful. The other thing that this group did, because it was so important to promote this work, it was quite difficult recruiting to this study. We had little mini conferences in different places in the UK, and the Lived Experience Advisory Group were a little bit like on tour. They were going around giving talks, trying to inspire other psychiatrists and other patients to get involved in the trial. They wrote study newsletters to try and show the work that was going on, and like they wrote opinion pieces in that to try and sort of stimulate debate. And 2 members of the LEAP actually got involved in some qualitative work that Nicola is going to talk about. So as I said, the kind of one of the unique things I think about this study is that we really tried to think about how our stories were how Radar had impacted on our stories. And as I said, we carried out this piece of work where each of the LEAP members interviewed each other and shared about how Radar had impacted on their medication journey over the last 5 years. And everybody wrote their story, and then they read their story to the whole group. So people worked in pairs, then they wrote something, and then we had a session where everybody read their story. And as a result of that, the group decided they wanted to get their stories out there. And we have developed 2 podcasts, and they're coming out soon, and I will let David know when they're available. And these are podcasts from the Radar LEAP, talking about their medication use, why they got involved in the Radar trial, and some of their tips and recommendations for practitioners in particular and other service users thinking about discontinuing. So very, very practical things can come out of this. Where next? So, in the UK, we've got probably a 20-year tradition of doing this kind of work. And I'm aware that in Israel there are the embryonic beginnings of this, and some people are doing peer research and are advising researchers, but it's not embedded. So I suppose where next is to think about how a network can be developed here and more of this work can happen. And in doing that, my kind of nudge is around think about diversity, thinking about bringing different perspectives in, thinking about making space for lived experience and leadership from the get-go. It's taking time to do that in the UK, so you could lead on that a little bit. Thinking about new models. So there is innovative work in this space, and a lot of the kind of actual detail of what we do is about providing a critical friend lens. What does that actually look like? You can say that I'm a critical friend within the study, but how do you do that? How do you land your critique so that it's well received? It's a very difficult space to work in, as we say, around, it is a very difficult space to work in. So what does the critical friend model look like? We need to be doing more work on this. How do we change the culture of research so it's less elitist? So there is space for people who have been very poorly and may feel very marginalised to coming in and working alongside Professor X, Y or Z. How do we create this culture of research that is a lot more open and flat, remove the hierarchies? And most importantly, check in with people who are experts by experience about what matters most to them, what research should we be carrying out, and how would they most likely to want to be involved. My last 2 slides are some tips that we've written about research collaboration. I'm just going to talk really briefly through, you can see them on the screen. So in a sense, 10 tips, because this work is involved. There's lots and lots of things to think about. So one of the things is about uncovering and celebrating individual strengths in the team. We feel that with research collaborations, it's really, really important to value the contributions of absolutely everybody within the team. We find that sharing personal experiences or interests really helps to level things, and we did a little exercise. We often do exercises in team meetings, opening icebreakers that really help to kind of do that in practice. We have to value vulnerability, we have to foster reciprocity, we have to be transparent about the limitations, and we have to prepare ourselves for differences of opinion. We have to create dynamic and consistent communication. We mustn't underestimate the resources needed to do this. We do need to think about diversity of perspectives and try and include lived experience as a core member of your team. Thank you.